Thank you very much for your kind introduction. It's lovely to be back in Cambridge. As a public health physician and data scientist, I'm often asked about artificial intelligence and the future of population health. And how can public health be an agent in a connected world? So I want to go on a journey with you today from examples of quite basic mobilization of data, but at scale, exposing the structure of those data to inform actions with alacrity, to really make a difference for potential population health gain, through to more forward-looking interactions, forms of artificial intelligence that change how you think about data and how you act in your health. Systems thinking. Is this new? No. If we go back to Hippocrates, father of medicine, the wider determinants of health are measured as he faces back against critics and said it's biology, not the gods, that cause disease. But thinking about the air you breathe, the water you drink, the places you live. 15 years ago, I wrote a chapter in a book that was looking forward to what next, beyond big databases, and there was a lot of polemic about big data at the time. What were the real needs to mobilize machine learning on data to improve human health? And I looked at two gaps, which was unifying disease understanding and shifting from millennia of health data being doctor-to-doctor communication to a future where your needs revealed in data in a more timely way could have a broker, which I called an avatar, the combinations of your records, predictions, and preferences in a much more interactive form. We'll get to that at the end of the talk. But first, it is Cambridge Philosophical Society, so I want to set this in a wee bit of framing in history and the relationship we have in public health to data. And where does that sit? In a medical framework or in a civic framework? Go back to London, plague, fire, civic data, and civic action in the 1600s. You see John Graunt's bills of mortality here, the number of hearths in a house, the rich houses having lots of fireplaces, and the poor houses with overcrowding having few, and the higher death rates here. The parishes were clocking up the deaths from Yersinia pestis plague with overcrowding. And this sits at the time of 25% of the population dying in 1665 in London. What's the political commentary? What's the philosophical framing of this for action? And John Donne, metaphysical poet, says, "Any man's death diminishes me because I'm involved in mankind, and therefore never send to know for whom the bell tolls, it tolls for thee." Germane to reflections on COVID-19, in the reflections on our own health and being all in it together, and how that changes how we act around data. We go to some regulars to Cambridge Philosophical Society then in the 17 and 1800s as probabilistic reasoning starts to touch medicine. Bernoulli and Moivre and probability theory postulating that should be applied to medicine. And then Laplace and Louis dare to apply probability theory to medicine. Huge rebuke after showing some treatments were positively dangerous. And the medical profession pushing back very hard. Adolphe Quetelet, here, Belgian mathematician, kilograms per meter squared, body mass index. In an essay, The Average Man, also pushed back as a heretic that how can you possibly have an average man? But we move then to the 1841 census, another regular Cambridge Philosophical Society, Charles Babbage. The difference engine model that he didn't have the precision engineering to build was built in Sweden, the Schweitzian calculation engine, a small version of the difference engine. But these were drinking buddies. And it was just used to do the long division of the 1841 census to construct life tables. We then start to get industrial with numbers. Joseph Lister producing an aseptic field for surgery with carbolic spray, really combining germ theory at the time, the biological reasoning together with a statistical framing that was experimental, showing that could reduce infections and death after surgery with these reduced sepsis techniques, or aseptic field. That sits at the same time as a vigorous debate around in this society, where we're moving statistics into a mainstream of thinking, into an ethical and philosophical framework for being experimental, from agriculture through to medicine. And then in the mid-1900s, the rise of experimental medicine, clinical trials, the foundation of the National Health Service. We have, Ronald Daimler Fisher moving from agriculture into medicine. Austin Bradford Hill really thinking about observational data and then into experiments, but discipline of not reaching the wrong conclusion. And sadly, we still vastly do reach the wrong conclusion with observational research in medicine. Through to Dole and others. Then we hit a decade of a glimpse of thinking about interacting with machines over a diagnosis. So cybernetic medicine in the 1960s and 70s was a quest for automation, was a quest for having a representation of knowledge. It was very basic, it was rules-based, but it started to overlay some Bayesian reasoning in that interaction, really like a consultation. We move then into creating the evidence and interacting in a diagnosis to reach a conclusion through to propagating knowledge in disciplined implementation and seeing what happens in the real world. What is the outcome variation in the real world with the evidence-based practice movement? Through the 1980s and 90s, we have the widespread push of computerization, particularly in general practice. At one time, there was 176 GP computer systems in this country. There was a big quest. Dame Edith Kerner in 1980, she pushed very hard for standardization of hospital data to compare one with another, compare like with like, which moved into the WHO, became the International Classification of Disease. So coding and classification, putting medicine in a form where one computer could talk to another, was done very well in the UK. Having clinicians codifying in machine-readable and interoperable forms, diagnoses, test orders, test results, procedures, etc., sat at the same time as here Julian Tudor Hart writing and reflecting after a decade of working to treat his practice like population health. So a GP in Wales saying, I really need to maximize potential population health gain. I need to use the data from my practice to hold a mirror back to me. How well am I doing with helping this whole community? So we have a mandate in the National Health Service to effectively maximize potential population health gain. We have data standardization that has pushed through. But what's happened since? We've bought computer systems, particularly for hospitals from around the world, where there isn't necessarily that social framing to maximize potential population health gain. And they've been engineered for a very defensive practice. So an alert popping up when there's a drug-drug interaction. There's a blizzard of alerts. You're blinded by alerts in most clinical information systems. Some of the worst engineered information systems in the world are around human health. They're defensive. They're not really fit for just-in-time reasoning and support. So these alert fatigues mean that a lot of prescriptions, about 4% of prescriptions estimated, contain an obvious error that should be screened out. We have practitioners who are very busy, so there's an alert fatigue. So my former team in Manchester here just did very simple implementation of, can you email a GP something after their surgery, when they're likely to be in reflective mode, and say, how many patients, click to identify your patients with asthma and a beta blocker here, which shouldn't really appear together. Can you weed those out? The answer was, with some hand-holding, with introducing that other route in to deal with the alert fatigue, there was a halving in the potential harmful indicators. So really simple intervention, some basic automation. Well, what have we got now? We have patients and GPs who face an app blizzard. Different interfaces, different alerts. And we have an existential crisis from antimicrobial resistance to healthcare practices, and in many respects, to quite a lot of human life. It's estimated that by 2050, if we do nothing, 10 million deaths a year will be attributable to microbes that we cannot treat with conventional antibiotics, other antimicrobial agents, because they develop resistance. So here's a very simple build on the previous feedback. Look, can we renegotiate? Can we target the use of antimicrobials so that it's not an automatic expectation of a patient? That isn't necessarily the best thing for them. Can we use future AIs that may ring you up and say, you've just booked an appointment, by the way, can we talk through your cough and cold? Actually, if you have an antibiotic, it might batter your gut bacteria, which render you more susceptible to a subsequent infection. And if you're susceptible to those infections, you might end up in hospital. The reality in the data is that is so. But the defensive situation of a patient wanting to come out of the surgery with an antibiotic prescription is very difficult to deal with at the moment. It's not a simple matter of engineering. So this system was designed with my colleagues in Manchester and GPs to just try and develop a conversation that is about antibiotic resistance, the risk of antibiotic failure, and holding something in reserve. So print out an information sheet for the patient, generate the code, goes into the system, saves a bit of time in the practice. That's out in clinical trials at the moment. But let's draw back the microscope here to something that's been described extensively from colleagues in Cambridge, which is the north-south divide in health experience and mortality. We draw a line between the Wash and the River Severn here, bisect England into approximately 25 million either side of the line. The 25 million up here, around a football stadium full of people every year die before their time, compared with those in the south if they'd had the same life chances. Classic north-south divide. But let's overlay antimicrobial prescriptions, hotspots of antimicrobial prescribing that might be battering your gut, rendering you more susceptible to subsequent infections. Understandably, because these are sicker populations with greater need for services, and those services are under huge pressure, and primary care is on its knees, we have the hotspots of antimicrobial prescribing in the north, making situations, north-south divide, worse. So many paradoxes in public health. And let me think about this as an engineer for a moment. You've got three learning loops that we'd recognize as healthcare around the population, so assessing a population's needs and investing in services to meet those needs, around the provider, quality management, around the person, improving your lifestyle factors alongside the care that a health service can deliver you. But there's another learning loop in antimicrobial resistance, which is pathogens and resistance mechanisms. I hear a lot about tackling antimicrobial resistance. It's to be lived with. It's an engineering problem. How do we have a pull-through of new antimicrobial drugs, new approaches to handling surface antimicrobial practices in a care home, in a healthcare setting, new expectations of the uses of antimicrobials, materials chemistry to have new antimicrobial surfaces that do not make the situation worse, better use of antimicrobials, particularly in farming and veterinary practices, not using them as growth promoters. It's a whole system engineering problem. We're going to have to tackle this, or a lot of healthcare will be on its knees, from microbes resistant to what we have to treat infections. That takes me to systems thinking versus component optimization. I hear a lot of oversold terms. AI, as you will know, there's a lot of hype around AI, but there's also a lot of potential. Another term is the learning system. If we look at this continuous learning loop across the provider, the population, and the person, there is huge potential to do the Kaizen better little by little, all the time. But this isn't new. When I trained here in Cambridge, there was talk of clinical audit, closing the audit loop. Observation, intervention, observation, intervention. Can you get a flywheel effect where you're titrating the amount of intervention to the need so that you're continuously improving? What is the cadence of feedback required? Can you pull all the data together so that you keep improving and then you change tack if something is not working? It might be thresholds for referral, thresholds for prescribing a drug, time that a patient should be in hospital after surgery, the length of rehabilitation. There are no hard and fast rules. We need to continuously evolve, particularly if we want to personalize to smaller groups. But then that knowledge generation, so knowledge to performance, performance to data, data to knowledge, this continuous cycle was given another label in the 2010s. Well, where we are is here and now. We have this huge need to learn from where the research is left, a massive gap. And that is in how multiple conditions work together. Most clinical trials don't include people with multiple conditions. In a medical science career, in many ways for good reasons, you're rewarded for knowing ever more about ever less throughout a career. So the system conspires against you to understand the system across diseases, mechanisms, specialties, and silos of data. But we face a situation in population health where more than 2/3 of the over 65s by 2035 will be living with multiple long-term conditions. Where I grew up, in Liverpool, in a relatively deprived area, and in all deprived areas around the world that are suffering big pressures from multimorbidity, the combination of mental and physical health conditions in particular arise much earlier in life, and they spiral together. So it's a vicious circle that is common around the world, yet we don't treat those conditions together. 1% of the population is on an antipsychotic medication, more than many people think. And many of those medicines leave you putting weight on, more susceptible to diabetes, puts up your blood pressure, heart attacks, strokes, big cardiovascular channel. So you might have someone seeing the stroke service, the coronary heart disease service, the chronic kidney disease service, and the mental health service, all afraid to change each other's drugs, particularly across the mental and physical healthcare divide. Yet we have integrated data from integrated records. We don't yet have integrated support of decision-making, particularly that involves the person themselves in the choices they need to negotiate with their care teams. So another issue we face is that these compound pressures, they hit us every winter. The NHS almost breaks in the winter. And yet many of the AIs that are being sold to the National Health Service are trained on data from more affluent parts of the world, or parts of the world that don't have high fidelity upstream primary care data. They're relatively crude algorithms. The frameworks are there to do a lot more, but they need to target on these areas that have massive pressures, particularly where the winter pressures are making a provider fall over. Someone in their own life might be under huge social pressure and integrated with social care services. And the population health is worse. So those deprived areas we really need to focus on. But not just towards the end of life, when people are at risk of being admitted to hospital in a winter that is harsh. They may live in a cold, damp home, but the next door house may have a young child who is suffering lifelong consequences in their lung development and in their brain development from living with a combination of environmental stresses, a cold, damp house, and maybe toxic stress that puts on the parents, and the bonding with the child, and their social development, and their brain development. Sadly, in Liverpool, I see 16 times more children than the national average taken into care. And that's a massive and increasing part of the local authority budget. Many local authorities in deprived areas are broke. And this is a huge public health problem, particularly when a third of your children are still born in poverty. When I moved back to where I was born in Liverpool 5 years ago, I saw this very alarming picture. This is infant mortality. And you don't see rises in infant mortality in the developed world as a rule. It's a sign of uncivilization. Yet fairly savage cuts to early life years support in 2010, just after a credit crunch. This was the infant mortality picture in Liverpool. So we couldn't ignore this as a public health and academic family. So we committed really to this children growing up in Liverpool birth cohort, looking at how poverty, disadvantage, and poor health gets under the skin from parenting, development, child health, learning, back to parenting. Can we really study this in a joined up way as a system? We clearly needed the data. So in late 2018, we committed to what we called City Lab at the time, which was a big conversation with the public over integrating data from the National Health Service, from education, from social services, with a research repository, including a triad design for birth cohort, i.e. genetic and other biological information, including on the microbiome, from child, mum, and partner. This is now in train. This is getting going, and it's committed to linking data that is core business for the care service, pulling in the consented individuals. This is 10,000 babies, so 30,000 residents, to have their data routinely linked from services into a secure environment, and the algorithms open to the wider scientific community around the world to mount in a way that you create an open innovation, open insight environment on the data. And this is a philosophy for population health engineering and not just a birth cohort study. It has the notion of nurturing the digital twin of the child growing up in a city. We think of civic artificial intelligence, i.e. the means with which we interact with services of where we live. What more could we do for the future than make that nurturing for the next generation? What more could we do than invest in those golden weeks and months and couple of years from conception to 2 years of age? support for families, and the overall interaction through AIs that could be brokered to give those nurturing opportunities. How does that work for the child? How do you create agency rather than invest yet more in AIs for us to be clickbait, to buy things we don't need? How do we develop artificial intelligence to nurture the digital twin of the child for their life? Do the public want the detail of data sharing that's required to support those journeys across many aspects of our lives? There are many ethical issues to sharing the data, to using the data in a trusted way on behalf of society. So we committed in Liverpool to open the Civic Data Cooperative, built on work that's been done over many years. In my former team in Manchester, I pushed forward with the Data Saves Lives movement. Time and time again, communities came back and said, don't presume to know what we want with data sharing. Talk about the actions you want to take from having shared the data, and come back to us and tell us what you've done. So the medication safety alerts, patients say, send us a text message, don't just do decision prompts for GPs. This kind of involvement is very task-oriented. It focuses on the actions taken and not just the end point being a big database. And it's been incredibly constructive. This is the result of a citizens' jury asking the community in Liverpool, are you happy for the pharmaceutical company Pfizer to work with detailed data looking at antimicrobial resistance? Yes, we got our marching orders from the public here, said please get on with it, but we want to know everything that is being done with the data, and we want lots of feedback on how you're going to act on the results. So this sits in stark contrast to a conversation around databases rather than actions, which is the care.data, the federated data platform, conversations, etc. Very different. Now, my duty as a public health physician is to work for a defined population. I say that is like working within a diameter of trust. Diameter is a large enough population, let's say around 2.7 million people is Cheshire and Merseyside. That's large enough to have statistical power, but small enough to take people with you in terms of fine-grained actions on data. This way of working has become quite gritty in a good way. So it's not just simple data sharing scenarios, but future AIs and ethical questions alongside very practical prioritization of actions that's brought colleagues from around the country to have fairly gritty conversations in Liverpool alongside members. Here's our communities creating here's a graphical model actually of factors in combinations of mental and physical health conditions, but with the women's health group, mental health group, and the factors they thought weren't considered in depth enough. This is about de-prescribing artificial intelligence, structured medication review for patients who may suffer harm at the moment because they have multiple conditions, multiple medicines, and there isn't enough money in general practice in this country to review everyone's medicine. So you have to work out who's most likely to come to harm, and this is a group of patients working out how they would like to be contacted by AIs, and you're welcome to have these slides and go through the videos. This wiring diagram follows that really social, deep piece of work to prioritize actions that are not being taken and say to create that physiology of data action, what anatomy of data plumbing do we need? This has moved from concepts born of a terrible situation with child health through to the Civic Data Cooperative that gave a social license, a mandate to go and act, and then we hit COVID. This was a real wake-up call for action-ready data. These slides show 18 million lateral flow tests. So the 2.7 million people of Cheshire and Merseyside here had no integrated record. But we had the Civic Data Cooperative that said, go and build one. COVID hit. We went and built an integrated primary, secondary, and public health care record, also with social care contacts, in 90 days. It would normally have taken 4 years, at least, to procure this, but using best practice information governance and the galvanizing situation of the COVID-19 pandemic, this was achieved in a very short time frame. The result of a 30-minute feed for these PCR test results and lateral flow test results was that different agencies were saying, what are we going to do tomorrow versus what we've seen emerging in the past few days? It changed the conversation of the tempo of action, and this was very, very valuable for coordinated actions across agencies. I actually had to be told off at one point for sharing data between Public Health England and the National Health Service. You couldn't really make it up. But going back to the diameter of trust, the agencies, the chief executives of multiple agencies, the organized efforts for society for this population said, the right thing to do is to link the data between public health services and the National Health Service. I faced these headlines, and this was really difficult as a public health physician. One headline in my local newspaper was just showing the vulnerability of a deprived population with a lot of background ill health. Then SARS-CoV-2 virus comes along, COVID-19, severe disease, bound to create more pressure. So there was a risk of intensive care units being overrun. But at the same time, there were families suffering toxic stress. Half of the jobs in Liverpool depend on the visitor economy, which had stopped, locked down. So domestic violence figures were going up, mental health referrals going up, particularly in young women. This is a very difficult situation to be in when you're looking at decades of potential damage alongside immediate risks of deaths of the most vulnerable. With our data system in place, it wasn't then difficult to say, okay, we will try something different to control the spread of the virus, but also to keep parts of society open that are important to the future of those families. So with 2,000 soldiers, we mobilized in just 5 days the first pilot in the world of voluntary mass testing, asking whether lateral flow devices deployed at scale for people with or without symptoms could reduce transmission. The result was that the known case rate fell by a fifth, detection increased by a fifth, and hospitalization with severe COVID-19 decreased by a quarter. The most humbling thing was that half a city came forward in a month, a quarter in a couple of weeks. So we were able to provide the evidence to SAGE within 6 weeks of how this worked. That required us to create an artificial Liverpool, taking all England data, looking at nowhere was exactly like Liverpool at the time, with the same background disease risks and hospitalizations, phase of epidemic curves, restrictions. Creating like for like, a synthetic control analysis is really, really hard. But doing this is very important beyond the pandemic. Our National Health Service is a massive natural experiment laboratory. And many of our public involvement activities say, patients and the public say, you have a duty to surface the natural experiment. Really hard in data science terms, but it can be done. This is a very conservative set of assumptions, actually, that led to a 43% reduction, was Liverpool's testing and other places weren't, the initial push with the military, and then 25% overall. But not just health data. Here's consumer data. We'd linked into this civic data cooperative approach the National Consumer Data Research Centre. And we had a suspicion that there was a plan to prescribe lateral flow tests by the NHS, via apps at the time. And we linked data, so we had live data for 30-minute feed on uptake of testing. We linked the data to the small area statistics of the Internet User Classification. And here you see classes like E withdrawn, very low uptake. And this is after adjusting for money poverty. So digital poverty was a more powerful determinant than money poverty of low uptake. So by December 2020, this is from the 6th of November through to the 10th of December, actually, 2020, we'd reached national policy that is going to be universal access, not prescribed by the National Health Service. We asked for support for people in isolation as well. We didn't win that argument. But we also faced a debate, which was an interesting philosophical position of science and society. At the time, there was confusion over a clinical test of having been infected with SARS-CoV-2 versus a public health test of being likely infectious with the virus. And the lateral flow test was that proxy indicator of infectiousness. Whereas the PCR test, it took 2 days to get the result, and in many ways it was oversensitive, because you remained positive long after you were no longer infectious. So we really needed to define the utility function. If we want to automate this in AI terms in future pandemic preparedness, we've got to have utility functions, like one over the time to percentage appropriate action. Actionable accuracy, reverse engineering the actions, really needing an engineering mindset to get this right and be disciplined, not theoretical debate played out in the media about the wrong utility function. So from military move through to socialization of community testing in 7 weeks. Also thinking about different utilities. There was a risk at the time of people in quarantine, not being in work, and they might be all of the members in close contact with a case who were on a fire appliance. Or there might be an ambulance crew. There might be a whole shift in the police service. Or they might look after critical infrastructure. There was a very big risk in COVID-19, quite a few times, to critical infrastructure. By replacing fixed time quarantine with daily testing, I go to work provided you're negative, thousands of days were saved. So key worker days saved, and we protected critical infrastructure in that way. The message from that AI that might contact you in the pandemic response is from let's all get tested to test before you go to, that could be go and see a vulnerable person or go to work. Really needs to move at speed. Then we go to spring 21. The World Health Organization defines public health. Health as a state of complete mental, physical, and social well-being. A lot of people have forgotten the social well-being side. Remember, we had those rises in mental health conditions, particularly amongst young women. And mixing is a really important part of social development. So the reopening of the cultural events sector is something we decided to put a safety net around with communication and testing. In Maybank Holiday 2021, over 12,000 people came to 4 events in Liverpool, where they were allowed to run the events as they would expect. They could wear masks or they couldn't. They chose not to, but they had to test negative beforehand, and there was very vigorous contact tracing. If someone tested negative, tested positive, their friends were rung up to say, please don't go to those events. There were only 15 linked cases, and at the same time, in a swimming pool nearby, there were 50 linked cases. So that was about the background rate. We'd created the zero-sum effect that we were looking for at a time of relatively low prevalence. Then we roll forward to Omicron. Mother Nature, again, its flywheel had overcome some host immunity, and we had a particularly infectious variant. This is the NHS staffing. This is numbers off work in my area. This is 2.7 million people, Cheshire and Merseyside, and these are the NHS staff off work. This was a huge problem as patients face greater risk at one point from not having someone to look after them than COVID-19 post-vaccination. So we rolled out dual lateral flow tests and answered the question, do nose-only swabs pick up enough? And the answer was yes, and that was rolled forward. So a quality assurance program continuously looking at the evolution of a virus in a pandemic and your risk mitigations have to move with the flow. Really, with socialized testing, remember when people were putting on social media the series of their positive lines of their Omicron journey? It is quite sobering to note at the time that NHS staff, we were doing that testing to get NHS staff back to work sooner. The CDC in the US had said, just go back to work after 5 days, when many people were positive well beyond 5 days. So this is an important lesson, but it's a lesson that is revealed in the rhythms of people's lives and their journeys. There's highly socialized testing. If I could say, what does the NHS know about me? So on the right-hand side is my care record. It knows I have pretty bad hay fever, which actually started here in Cambridge, but forgiven Cambridge for that. It doesn't know the experiments I do to avoid taking antihistamines. I want to maximize mental acuity for my job. I minimize alcohol, increase exercise, I focus on sleep to live through hay fever season. But that probably is a series of physiological experiments, which are really important predictors of my future health. If we were able to tap into the rhythms of life in that way, in a world where we increasingly wear biometric devices, and we can gather symptom information by future AIs ringing us up, seeing how we feel, then you'll start to reveal phenotypes that are something like this. This could be mood fluctuations, or twitchy lungs with asthma, or a runny nose, and this a rapid fluctuating pattern and a slow pattern. They might have the same diagnosis, asthma, depression, but they're quite different biological phenotypes. And there may be different types for drug discovery. There may be different types for combinations of lifestyle factors and therapies in a health service. We really need to maximize the treating of a journey and not the diagnosis here. In many ways, a diagnosis-focused approach takes us away from the most treatable area of outcome variation, where we should be really putting our attention within individual experiments of how did we get on with the previous treatment? Why didn't we respond as the average patient last time? That's quite personal to your own motivations, but is it really revealed to you? Many of our most vulnerable patients with multiple conditions now face one app per medicine, per device, per clinic, and treatment burden is already too high. So just practically, in terms of the business failure of health technology there, we need to move away from separate apps to the integrative skills of your digital self that interacts with you. So it makes it easy. You have one form of interaction, and it learns how not to annoy you, learns how to support you, and one skill borrows strength from another. And that cannot be created by companies working separately to optimize their own treatments with single treatment companion AIs. This market is broken. So we committed in the Civic Health Innovation Labs to take this as a public service duty, to create the Health Avatar Interactive Digital Self framework by working with patients, practitioners, and designers and engineers to say, how do you create a technical framework that is practical for dealing with maybe someone who's seeing the mood clinic and the pain clinic separately, and the mood and pain intimately related. How do we reverse engineer the best integration of care? How do we reveal information that someone can take action themselves, maybe with their treatment adherence, maybe change in diet, physical activity alongside medication? How do you bring this alive for people? How do you give back greater control over your own life? And we know from the Whitehall studies and many others that autonomy, control over your own life, is a massively important determinant of health and very poorly understood. Autonomy as individuals and as communities. So this framework sits here to look at very concrete examples at the moment of moving to measurement-based care in one of the most difficult areas with massive outcome variation, which is in mental health. We've grounded this in mental health, but linking through to interactions with physical health. If I consider then, what do we throw back into the lab? What do we throw back to people who are working with mechanistic reasoning? I'm looking at symptom fluctuations here in mental health, positive and negative symptoms. Am I agitated? Am I incredibly down and withdrawn? Is that revealed in my movement? You know, if I'm an elderly person and social care is just using a new radar technology to see, am I safe? Am I being beaten up by a burglar? Am I stumbling and falling? There's approximate biometrics. It's tremor, there's subtle things, approximate heart rate and respiratory rate. Many ambient sensing technologies and AIs in future will come in for one purpose, but they may be used for another. And here we need not only how are you feeling responses to an app, or maybe an AI that rings you up, but different modes of data coming in to really deal with this very common situation, that inflammation of the brain and peripherally affects our functioning. It leads to schizophrenia, mood disorders, cognitive impairment, dementias. Brain inflammation is very, very common and complex, and it has time-varying patterns that are barely understood because we don't look often enough. Yet there are increasing papers on peripheral markers, of blood tests you can have for inflammation chemicals that then reveal something that's happening in the brain, which is these regulatory T cells, so immune cells, that are there to regulate function of immunity, which is also important for nerve development. Neurons, microglia, astroglia, the apparatus in the brain, very, very sensitive to immune regulation. So we're looking at the moment of some concrete trials, repositioning low-dose methotrexate in treatment of psychosis, but first very carefully looking at patterns of immune fluctuation in people with mental health conditions. Set this against COVID. So here's from my colleague Ben Michael and Greta Wood in the COVID CNS study. Pre-vaccination, looking at people admitted to hospital with COVID-19, there was about 20 years of brain aging from having severe COVID. But there was also a lot of brain aging for the group admitted with influenza. So highly motivating for people to think, well, what risks am I mitigating? And you've got not widely publicized risks like this. So maybe in the future, and one of the things we're looking at the moment is, do we need in our bathroom cabinets a lateral flow test and a best guess antiviral for a future pandemic? How quickly can we mobilize that? A lot of these scenarios need to be thought about. Sadly, we live in a world where wonderful technologies that can create pathways for new cancer drugs, as we've heard about, can also alter the virulence of pathogens, and in the wrong hands, the risk of bioterrorism is increasing all the time. So we must be prepared for the next pandemic, and we must be in people's consciousness about what this could mean to their future. So I've given many examples of really needing to understand mechanisms in a conventional way that medicine does really well, particularly in this country. Mechanistic research, very disciplined, and has great results. But there is this vast gap in understanding of putting the mechanisms back together, understanding how to treat people with multiple conditions. Yet we gather more and more data from people's daily lives. And there is a big data science challenge to bring together the understanding of mechanisms and the explaining of variation in outcomes. I really mean going back to those people who are not like the average patient, digging deeper and saying why. There is huge discovery potential in the data and the biological samples if they're taken at the right time and in the right sequence from those patients. This is a very different data science challenge from teaching an autonomous vehicle to navigate the streets of Cambridge, where the data are a relatively unbiased representation of the problem space. If you think about human health, there is so much missingness and measurement error in health data. We get tiny little glimpses in this massively complex moving target that it's nowhere near the machine learning AI problem of teaching an autonomous vehicle to navigate the streets. We have a relatively constrained situation in a lab. We have wonderful things. We heard about AlphaFold earlier, fantastic. But the real complexity of population health, we have to consider that we're looking at the problem space like looking through a doily, through a prism, at the problem in the data that we actually have. Therefore, we need to borrow strength from multiple populations and the structure there and impose that structure on the data that we're looking at for our own population or study population. It's a different philosophical way of approaching the data science, but it's a really important discipline. And I reflect the choice that my late mum made with her lung cancer. When presented with the evidence of likely experience with chemotherapy, she said, "No, I'm 81. I want to die, thanks." And that was her choice, but it wouldn't be everyone's choice. So the AI can produce the evidence which it thinks is right for you, but you and maybe your advocates need to blend values and evidence, which is, in a way, uncomputable, rightly so. So we need to create these flywheels around the person, the provider, and the population, continuously learning the automation that we can achieve with machine learning, artificial intelligence, data at scale, but interaction and experimentation that's trusted and used by our communities and prioritized, where we'll get maximum potential population health gain. My prediction here is that we will not advance population health without having a more interactive form of your digital self, whether that's helping you to use the lateral flow test and the approximate antiviral in a future pandemic in your bathroom cabinet, or helping you to titrate your journey, maybe reduce alcohol from your brain inflammation, alongside other conditions you may have. That blending of data and behavior, I'd put that as the health avatar framework. It's a combination of records, predictions, and preferences. I think that's a really important part of population health, not just individual health for prevention, early intervention, and precision personalization. But it's a vital part of understanding how to improve population health. In a way, we need the ground rules, the weighting for potential population health gain, really back to Julian Tudor Hart, those values of public health encoded in AIs, where they're trying to put the different pieces together in a system that optimizes something. We need a framework of values in there. And if we can do that well on a number of communities that invite in deep experimentation, we could borrow strength at scale. And for me, that's more a civic effort than a medical effort, but a vital one for maximizing potential population health and augmenting that with future artificial intelligence. Thank you for listening.